Continue. Thank you.
So sorry. Thank you. Now we're recording. Was that it? Thank you, Lorianne, for making sure that we covered all the bases. All right, Dr. Desai, take it away.
Thanks, Doug. Yep, thanks, Doug. So I'm going to talk about the Georgia Colorectal Cancer Control Program. We'll give some updates on the program. Here's the overview of our program. I know that many of you on this call are providers at clinics that are part of this program, but sometimes it helps to just have an overview of the actual partnerships that are involved in making this this program happen. And so Georgia Core is the cancer coalition based out of Atlanta that's in charge of the activities under this program. We also have lots of great partners. East Georgia Healthcare Center, I know a lot of our providers are part of that clinic or part of that health system. Also AAPHC is the other health system that many of our providers are part of that are participants of this program. Horizons provides patient navigation. Of course, we have a university partner with Augusta University and Georgia Cancer Center. And then Phoebe is one of the health system partners from Southwest Georgia. Next slide, please. So some of the activities that we're involved in, again, all of our providers that are part of this program, you probably have seen some of these things been going on, but this just kind of puts it into perspective. So we have evidence-based interventions. These are things that the CDC has done studies on and has identified as activities that help increase colon cancer screening rates at clinics. So things like patient reminders, these are things like text messages that we've been sending out to patients. We've done some campaigns on patients that are eligible for screening, and we send them reminders. Provider reminders, that's things that like huddles, or where the MA identifies a eligible screening and they noted in the chief complaint or in a sticky note. Those are provider reminders. Reduction of structural barriers, those are things like gas cards, which I know that we've been passing out. And so if you are a provider at one of our clinics, you probably know, but if you don't know, it's something that we do have access to for our patients that need transportation to their colonoscopy appointments if they have a FIT positive. And then provider assessment and feedback, that's things like what we're doing now, talking about getting patients screened, talking about screening rates and talking about barriers to screening. And that's kind of what we do through Project ECHO. We also do patient navigation. And then I'm going to talk a little bit about CRC champions as well during the end of this presentation. Next slide, please. So this is just, I'm just going to go through this very quickly. This is just to show that we've implemented these programs at clinics at different times. The majority of our implementation at most of the clinics, if you can look and find your clinic, was actually in March and February. But then with some of the other clinics, we implemented in 2021 as well. So next slide, please. All right, so this is a slide that shows how hard everybody has been working. And it just goes to show the impact of this program in a really relatively short amount of time. And so what we're showing here is the screening rates. And so we have baseline screening rates and then the most current rate that we had. The baseline was before we officially started doing these implementation activities, things like the patient navigation and some of these other interventions that we've done. And then the current is the most current that we had for Albany area primary healthcare was October. And the most current we have for East Georgia Healthcare Center is November. So that's November 2022. So if you guys are looking at the rates, it's pretty impressive. At Albany area primary healthcare, they had already started participating even prior to this program in some of the things like patient navigation. So some of their rates were already started higher at a higher baseline, but even they had some pretty impressive increases. And then East Georgia Healthcare Center is newer to some of these interventions, and we're seeing some really remarkable results there. I mean, in really a relatively short amount of time. I remember in the last slide I showed that many of the clinics had just started implementation in 2022, and so and we're still in 2022, and we're already seeing numbers go up. We're seeing 8%, 13%, 18%, and so really just some remarkable things that we're seeing, and that just goes to show how hard our providers are working to get our patients screened. One thing that I do want to mention on this slide, so this is based on UDS, so those of us that are familiar with FQHCs know that there's UDS reporting of of certain metrics. So they've been reporting on for colon cancer screening, as far as who's considered eligible, is patients that are between 50 to 75. That's what we've been using. As we all know, and those of you that have been participating in these Project Echoes know that the new guidelines show that it's supposed to be 45. And so starting in 2023, as Dr. Hotz likes to say, the goalpost has moved. And so now we're going to have to start tracking from age 45 to 75. So now we have this whole new group of patients that we're going to get dinged if we're not getting them screened. And so just to keep that in mind in future years, I mean, it's something that was already part of the guidelines, but now the UDS is going to start tracking patients that are between 45 and not just 50, but 45. So we have this whole new group of patients that we really have to pay attention to and really help get them screened. And that's the reason they did that, was because there's a bigger incidence of younger people getting colon cancer, and really late stage cancer at earlier ages. And so to try to prevent some of those deaths, that they reduce the age to start screening. Of the next presentation, or sorry, next slide. There we go. And so this is just to show, you can kind of compare your own clinic to where other clinics are at, or the previous time this program was, the CDC program was implemented was about 5 years ago. And so at that time, they were tracking all the clinics to see how they did and get an average of to see what kind of screening rate increases they had. And so in year 1, it was 4.5%. In year 2, it was 8.2%. Year 3 is 8.4%, and year 4 is 12.3%. And so if y'all remember, with our clinics, even within a year, many of our clinics are already above that. So we're already doing better than previous years. But the thing is, we have to keep this rate going and keep this going, because as the years go on, we're expected to do even better. And so we need to, keep pushing forward to make sure we keep working and getting our patients screened, to make sure we keep building on our success. Next slide, please. And so the goal set by the American Cancer Society is 80% in every community. And that's kind of what the national goal is for all clinics and at all centers. And that's kind of what we always try to strive for. Next slide, please. But we also know it's obviously we the kind of patient population we deal with in our FQHCs and in our underserved population, it's very hard to get, all of them screened. And so the CDC gave us a little bit of leeway. And so their benchmark that we're trying to reach is 60%. Luckily, we've already reached that 60% in a lot of our clinics, but other clinics, we still have some work to do. But we still have time as well. And so this is just as you guys are looking at your rates, seeing, where are we doing good enough? We always want to see improvement. That's the most important thing. But as far as what benchmark is, it's 60% for the CDC as part of this program, and 80% for clinics, according to the American Cancer Society overall. Next slide, please. All right, so how do we get to 80%? So there's, we've all been working hard, but we know just from research that the CDC has done, more interventions lead to higher rates. So we know that the more interventions that we're doing, the more that we're working on in terms of these type of things like provider reminders and patient reminders, the more likely the patients are to get screened. And the other thing is consistency in these interventions. So are we doing them consistently? So are we doing these morning huddles every morning? Are we doing things like patient reminders? Are we doing them more often? And so these are things that we know help with increasing rates and getting to that 80%, is that consistency. Then it's things like patient navigation, and then CRC champions. So that's what I'm going to talk a little bit about in the next few slides. And so you can go on to the next slide, please. So in addition to all these interventions, it's really important that at the clinic level, we have people and providers and staff that are more or less a point person and an advocate for getting patients screened. And this technically applies to all kinds of screening, but of course, this program will focus specifically on colorectal cancer. But these are providers and these are staff that are working to motivate other people within the clinic. They're doing things like tracking screening rates. They're doing things like when we have a screening policy, they're tracking to make sure we're following that screening policy. They're making sure we're doing things like identifying patients that need to be screened. And so they're really an enthusiasm. The most important criteria is really that enthusiasm for really making sure that we're taking the best care of our patients by getting them screened. And so then the other part of that is just understanding what program resources are available to increase screening, because we have, you know, certain things that we can provide through this program. If people are acting as that champion and they understand those things, they're able to act an intermediary in making sure that we're able to get those resources to the clinics. Next slide, please. So as far as what's the benefit of a screening champion, this was the CDC has done this program before, and they tracked all of the different resources or different things that they recommended, different activities. They tracked to see what kind of impact that had on screening rates. And so if you see on this, it's kind of small, but and so this was one of the characteristics they tracked was CRC screening champion. And so if you go all the way on the right, you can see there's a change in screened patient count. So this is the change in patients screened after 1 year. The first line is for patients that for clinics that did have a screening champion. There was an increase in 4.8% of their screening rates. In clinics that did not have screening champions, they actually went down 1.8%. And we can't say that was just from the screening champion, but we can say that screening champions are valuable. Next slide, please. So my call to action to everybody on this call, especially our providers that are part of clinics or that work in the clinical environment, is to become a champion. And so the most important thing is just to be motivated. Is just to track your screening rates. Is to make sure that, you know, we're seeing which patients we have that are part of our panel that are not screened, and then also helping the rest of our clinic and our staff staying on top of their screening. One of the next presentation is going to be from one of our really high performing sites, and she was saying how all of her everybody at her clinic is a champion because they all work on getting patients screened. They're all highly motivated, and that's the kind of thing that really makes a big difference when we talk about increasing our screening. And so the people that are part of our program, that are clinics as part of our program, one of the things we're going to work on is trying to engage our champions more. And so y'all can keep you guys updated on what kind of things we're doing and what kind of resources we have to offer. So the last thing I'm going to say is let's work on getting our patients to 80% screen, because that's how we're going to save the most lives and prevent colon cancer deaths. Next slide, please. And so I think on this call, I'm sure we have clinics that have used screening champions before, or that act as champions. So I don't know if Robbie's on the call or somebody from that team, or Dr. Hotz, they can comment on clinics that have had motivated champions and what kind of impact that's had.
Yeah, I'd be glad to add to that. Our program goes back 20 years, even before the CDC. And what we found is that, you know, the key ingredient of a champion is enthusiasm and connection with why it's important. People who have had colon cancer deaths in their family, like I have, it becomes personal, and it's something that motivates you. I right now take care of a lady who's 46 years old, never screened, with stage 4 disease. And, you know, we know what her outcome is going to be. We've kept her alive with a lot of the new biologicals and treatments at a cost of $200,000 a year and a lot of side effects. And what we see in our clinic system, where we have over 12 adult clinics out there, those that have a person who's really pushing can get the job done. We have one clinic that every demographic would say it should not perform well. It is poor, rural. 90% of the patients are African American, and they will, this year, they're like 12 patients away from getting over 80%. But it's been somebody in the back of the clinic that's been pushing. Now, interestingly, the spillover effect is their breast cancer and cervical cancer screening rates will probably hit 80% too, because when you're pushing one, the other one gets pushed. And the other one that we've found to be very effective is we run the largest rural HIV clinic in the country. We manage over 1,400 HIV patients, poor, rural, minority, LGBTQ who are suffering with AIDS. And they're now over 60% colorectal cancer screening because of the relationship that is so intense between the folks that are being seen so often for HIV and the clinicians working there. They develop this bonding and realize that you can really make a difference in people's lives. And so they're also pushing the same in breast and cervical. So never underestimate the power of that clinician to get the job done. And so, and you'll see nationally, the clinic systems that work really well usually have an internal person. So we have found it to be extraordinarily important to get it done. And it's also a lot of fun when you have enthusiasm. When somebody is pushing and challenging each other and then competing. We've got a trophy we're ready to give out, and it's called the Triple Crown of Cancer Screening. When one of our clinics gets above 80% on all three of them, we've got a trophy ready to give them. So just some of ideas about, how to get there, how important it is, and the fact that, you can work at a community health center with a bunch of uninsured people and can get the job done.
Thanks, Dr. Hotz, for those comments. Others who might want to share their own stories about having a champion in place that's helped me. We'll hear from Myiesha shortly, so she gets passed on this part of it, but others? So I'll pose a question, and this could be for either Dr. Hotz or Dr. Desai. Does it have to be a clinician, or can someone else in the clinic setting become the champion?
Yeah, sometimes it doesn't have to be a provider. I think it helps if at least one of the people that are acting as champions is a provider. But we have clinics where there is, MAs that are highly involved, and we have clinics that are, in fact, if we have a multidisciplinary approach, is actually more effective, I think. So you have multiple people kind of working towards the same goal and being enthusiastic and motivated. So that would be my kind of my take on it.
Yeah, and what we see also is that the combination of a clinical champion and an administrative champion, our really high performing one, have the front desk and administration in lockstep, with the team. It's like having an enthusiastic quarterback and also a coach, all aligned with the same goals and the same vision. Now, nobody doing it for their personal glory, but all want the team's success. And that's when you really start functioning. But that enthusiastic, clinician, the gal that's going there to win and has a goal of excellence. That's what we find really drives people. Now, 60% is actually the 90th percentile on UDS. So, most of us on this call today were A students. 90 was usually what it took to get an A. So if you're above 60%, you're getting an A compared to other community health centers. And also remember the people we take care of. For the uninsured people, the national screening rate is 30%. So when we're lifting it to 60% at a health center, that's a hell of a job. But I think that front desk back alignment, and then, having enthusiasm by that support staff, the medical assistant, that is a real key combination.
Well, I'll go back and revisit one of Dr. Desai's slides where he talks about how to get to 80% and consistency in interventions under that category. The thing that strikes me is sort of the Swiss Army knife of interventions, if you will, is the morning huddles, because it gives you an opportunity to get the entire team from the front door all the way through the entire process, engaged in conversations about colorectal cancer screening. But then, as you mentioned, Dr. Hotz, it spills over into other screening efforts, but it also gives you an opportunity, if you're consistent with your morning huddles and you make sure that you're covering consistently some of these priorities, helps you with your patient experience, the evaluations that the providers can get about how the patients are doing in general, and also just managing the flow. So I think that's if I was going to call on anything to make sure that we're doing it consistently, it might be that concept of a morning huddle. And I think that's something that can be done no matter how big or how small the clinic staff is. So any thoughts on that before we move on?
No, I think you're right, Doug. And the other thing we got to remember is to celebrate success. You know, if you, like Georgia just won the SEC championship, they get a banner for that always goes up, that they can always remember at one time Giants walked these halls. And, you know, that's also something to remember, that medical office assistant who ground out all those calls and got people in, the navigator, you know, turning back and having an organized way to celebrate that contribution to hanging banners is always an important thing to do.
So hanging banners in your waiting area about colorectal cancer screening might actually be a reminder to someone that they need it done. So there you go.
Yes.
All right. Well, we can continue to take questions or comments in the chat, but I think what we'll do now is we'll go ahead and move on to our case presentation discussion for today. And it's going to be led by Myiesha McFarlin, who's a nurse practitioner with East Georgia Healthcare Center in their Soperton clinic. And today she's going to present on CRC screening success at the Soperton clinic. And if you were watching as Dr. Desai went through those comparison before and after, they had an over 18% increase in their colorectal cancer screening success rate as reported on the UDS measures by implementing some of these interventions. So we're eager to hear from you, Myiesha. Thank you for joining us today to present. And at this point, I'm going to turn it over to you. There will be a warning ding about 8 minutes in if we need to make sure we're watching the time. So thank you.
Hello, everybody. Thank y'all for having me today. So next slide. All right. So we are here in the Soperton clinic. It's Soperton is about a population of 3,000. So this is just our general population of our Soperton clinic. So we probably see about 1/3 of the population of Soperton here in this clinic. So we see about 39 Hispanic patients as of this year, about 400 white patients and 463 Black patients. Our insured population is 706 and our uninsured is 218 as of this year. So next slide. So I personally came to this clinic last year in October. I was working in the Swainsboro clinic beforehand, and we had started implementation of the program there. So I kind of brought what I learned in Swainsboro to the Soperton clinic. So this is basically our screening rate. Last year, the screening rate in Soperton was 35% overall. This year, we're at 52% right at the end of November. So our uninsured screening rate, this number was kind of important to me. I feel like our uninsured rate our screening rate went from 10% to 40%, and then our insured rate went from 40% to 53%. But that uninsured rate really did jump for us, so that was a big deal for us. All right, next slide. And so this just shows from our implementation kind of at the beginning of this year was last year in October was 34%. And now we're at that 52% at the end of November. So next slide. So pretty much our interventions, we're doing the text messaging, we're doing chart prep. Chart prep is really important for us. We have our morning huddle that kind of lets us know what the patient needs. My MA is letting me know what my patient needs. I'm going through each chart with the MA, so I'm seeing what the patient needs. We put their needs as far as all UDS measures right underneath their chief complaint. So that's kind of the first thing you see in the chart. For me, that's what I go back to when I see my patient. So, if they came in for their blood pressure, it's blood pressure, and then it's their UDS measures. So I'm addressing all those things in their visits. So we're addressing structural barriers, the gas cards, the colonoscopies are funded. Everybody loves things that are funded, so that's a good thing. And then the prepaid envelopes where, so the patient doesn't necessarily have to bring back the envelope with the HemoSure in it. They can mail it back. That's a big deal. So for us to get our screening rate so high, it was a little bit of a pride thing. Like, we were kind of the lowest clinic at East Georgia at the time. And so our group of 5 here in the clinic decided we were going to take this on and we were going to improve our rate. And we really did do that. And then patient navigation is really important to us as well, because it takes kind of not the responsibility, but it takes a big pressure off of our MAs, because once we get the HemoSure back, then Horizons is navigating that for us. So that's it really does help us want to get the HemoSure back, because we have somebody else who is helping us. So next slide. So pretty much this is kind of what we do when we get somebody who we identify needs a colorectal screening. So of course, our MA preps our charts in the morning. She uses our CDSS, which is on our charting system. She puts it in the chief complaint, and then it's on our huddle sheet every morning. So every morning, like I said, we're looking at the chief complaint. We're talking about it in the huddle. So that's 2 ways right there. We're already seeing it. Repetition is always good. So then I'll see it again several times throughout the day when I'm seeing the patient, before I see the patient, when they come, and during the visit. So then the patient comes in, we know they need a HemoSure kit, they need some kind of colorectal screening. So we talk to them about it, tell them how it is, what's going on, kind of explain to them what it is, answer their questions. A big thing for us is, so the MA will give the patient the HemoSure kit in the bag. And I try and tell them to leave it on the counter when I go in the room, because if I see it on the counter, then I make it a point to say, hey, don't forget to bring that kit back to me. They've explained to you how it works. It's super easy. There's several ways you can bring it back to us. And patients really respond to me saying something. I mean, the MA can tell you 2 or 3 times, but if the provider actually says, hey, bring this back to me, then they'll take heed to it and bring it back. So we get the HemoSures back. They can mail it in to us. They can drop it off. There are 5 of us in this clinic, and we have all been here, for the same amount of time. We've all been together. So we're all kind of on one accord. So if a patient calls and says, hey, I've got this HemoSure kit, then the front desk, the office coordinator, everybody in here knows what the process is. So we're all on one accord, and it's, hey, you can do this. Hey, we're here until 2 on Friday, so bring it back by 2. If you can't, bring it to us on Monday, or, things like that. And so then we run our HemoSures in office. So we get a result, within like 5 minutes. At that point, we assign the HemoSure to Horizons. So if it's negative, great. Horizon gets their negative result. They assign it back to us. Patient knows they're negative. If it's positive, then we still send it to Horizons, and they, kind of send us a message that, hey, this patient's positive. Can you put in the referral? So at that point, I get the referral back. I get the lab back, the HemoSure lab back. I put in the referral, my MA notifies the patient, and this all kind of happens within like a day or 2's time. I personally don't like to leave things, leave like labs undone. I'm a little bit OCD about it. So anytime I see something like that, I'm automatically, telling my MA, hey, can we notify the patient of their results? And then whoever notifies the patient, if they're positive, they know all about how Horizons navigates navigates the positive results. And so we can give them all kind of information, and patients really appreciate that. So next slide. Of course, there are barriers. We have to remind patients all the time. We've had to give patients 2 or 3 kits. Usually that my MA, she'll come in and she'll say, whichever one does it, they'll say, well, I've given them a kit, 3 times. And on that 3rd time, I'm like, hey, you got to bring that back to us. They take a little coaxing, but usually they'll bring it back. Lots of people are worried about the financial concerns. Like I said, everything comes back to money. So they want to know who's going to pay for this. They want to know, how am I going to get there? I don't have transportation. So Horizons does a lot of that for us, and we're very thankful for it. It works really good that, like I said, everybody in the clinic kind of knows the process. So when somebody calls and they have these questions, or they're positive they have these questions, then we can kind of give them ease their mind a little bit. So then when Horizons calls, they're more likely to want to go get the colonoscopy done. And then of course, some people just don't want to know. I've heard, I don't want to know. I don't want to know until it's too late. I don't want you getting my poop because that's my time. So, I'm like, you poop more than 1 time a day. So, I can, but anyway, so, you just have to explain things to them, educate. And usually they come around. I have a few who are very stubborn. So I see pretty much the same people all the time. So I know who I can kind of coax into it and who I can't. Next slide. So reason for success. So a lot of it was we took kind of notice that we were on the bottom of the totem pole here at East Georgia, and our clinic decided we were going to turn this around, and we really did. But using the interventions, using the huddle, just kind of educating the patient. We order the HemoSure, and I know it's a little wasteful to give somebody 2 or 3 kits, but we're technically only giving a few people 2 or 3 because most people will bring them back to us. Again, we've had the same 5 people since I've been here. So everybody's kind of on the same page. Earlier we were talking about how we have like a coach and then the quarterback. Well, everybody in here is like, all fits over here. Everybody's on the same page. Everybody knows what we need. My MA can tell you everything that I can. Our front desk patient rep can tell you everything about the process and everything like that. And that makes it super easy. The fact that all of our patients kind of know who we are, they trust us. So they're more likely to kind of listen to us as well. Navigation, of course, works great. It helps that there's somebody who, if you have a question, you can call them. We call them probably more than they would like as well. But they are always helpful to us. So we have our CRC champion here is everybody. Like I said, we're all on the same team. We're all working together doing these things. And we're all in one accord. And then, like I said, we just wanted to kind of be the best. So we're not quite the best, but we're close. Next slide. So that's it.
Good timing, Myiesha. Thank you for sharing that. I can sense the enthusiasm. I had to smile when you talk about sometimes it's a little bit challenging to talk about poop. When we're dealing with pediatric patient populations, that's a normal part of the conversation. But adults don't like to do that. Although now there are lots of TV commercials that confront us with the reality that we all poop, and so maybe that's a door opener.
Yeah.
I was looking to see if there was any questions in the chat, and I don't see any right now. So the floor is open. If you have a question you'd like or a comment you'd like to make, please raise your hand and we'll try and identify you and call you out so that you can comment. I will just highlight one thing that Myiesha pointed out. Again, she talked about the entire team being the champions. That's the strongest possible model for sure. And the process that they do with the registrations and the MAs before she ever sees the patient to identify the gaps in the UDS measures is an incredible if you can hardwire that in, I mean, that becomes something that every time you see a patient, you know that you're, keeping them up to date on their things. Was that something that you only do in your Soperton clinic, or is that across East Georgia, Myiesha?
I believe we all do it. We kind of, I think maybe every clinic has had some, not changes, but some things they want it done where they want us to really focus on the UDS measures. And so they mentioned putting the UDS measures in the chief complaint. Our clinic had been doing that for a while, and then I think every clinic kind of East Georgia is now doing it. So it really does help.
That's great. Still scanning for hands. I don't see any up. So I'm going to take a moment here and just acknowledge that while our focus for this grant and this project and this work is focused with East Georgia Health Center and then Albany Area Primary Healthcare in Southwest Georgia, there are people on this call, and I may have missed some people, but I see people registered from Louisiana, from Texas, Nebraska, Illinois, Michigan, Kentucky, and even someone from the Alaska Tribal Health Consortium. So we're really attracting a lot of attention with the work that you guys are doing here in Georgia with this. I would welcome someone from any of those out-of-state partners who have joined us to just contribute a question or a comment about why they're joining us, anything. I'm especially curious about the folks from the Alaska Tribal Health Consortium.
Yeah, thank you. This is Diana Redwood up in Anchorage, Alaska, where we just got 2 feet of snow last night. So I've
Oh my
shoveled
gosh.
4 times. Any rate, I guess I had a question regarding, you said, I believe you mentioned that you gave taxi vouchers, and I'm just wondering how many patients take you up on that? Does that seem to be really helpful? How does that all work?
Myiesha?
So I'm going to admit that I'm not sure. Usually Horizons is kind of the one that's managing that and that navigates our patients with that. But so since we've kind of been keeping track of it, I've not had anybody say that they couldn't go to their colonoscopy because they didn't have a ride. So either we're doing transportation or whatever they're doing is working. So I'm kind of don't know how it works beyond me getting them to navigation. But like I said, I've not had anybody say they couldn't go because they didn't have transportation. So I'm assuming it's going good.
Yeah, I can explain that. And I'm the medical director for the side there where we have our transportation and navigation. One of the things we found a long time ago, if you get an open door, that you have to make certain people use it to get that colonoscopy done. So the navigation team looks at barriers. It is done telephonically. It is part of our CDC support program, but it's also part of a local regional support. One of our partners, Phoebe Putney and the state, put money into having a navigation process that's telephonic. So and I chair the Community Health Center Committee of the National Association for the National Colorectal Roundtable. And the biggest stumbling block that takes enthusiasm away of great champions like Myiesha is if you get a positive FIT test or HemoSure and you can't get a colonoscopy. Nationally, that rate, interestingly, is under 50% for commercially insured. So the navigation program that has been installed telephonically that the CDC did a write-up on almost 20 years ago has a show rate of 90%. So what they do is, that hardworking clinician and her team like Myiesha, once she's got a positive FIT test, they're handed to an organization whose expertise now is to make certain they get them to colonoscopy, get it done, and get the results back. So for our colleagues, I think that's one of those important ingredients to any successful program is having a navigation. Of course, Harold Freeman showed that with breast cancer 25 years ago. Stage of disease after a positive mammogram goes down significantly with navigators.
Thanks, Dr. Hodgson. That was a great question, Diana. I think you can see it. It's kind of woven into the grant, but there's been plenty of evidence for decades to do that. Martin Sheldon, you have your hand up.
I sure do. Myiesha, we're very proud of you and a little bit jealous. So you've kind of, put a gauntlet down, and I'll show you, we have a couple of our MAs who are listening to your presentation. You want to say hi, Bree? Say hi. And it's like, so we have to figure out a way to match Soperton's numbers now here at Swainsboro. So you've kind of laid down the gauntlet there, but you also have a tremendous amount of enthusiasm, but you have a wonderfully tight-knit office, and you obviously display a lot of leadership within your little group there. And how do they feel about the fact that they've been so successful? Are they aware of how successful they are, and do they feel good about what they've accomplished?
I don't think we were aware until yesterday. So we were kind of going over the slides and we saw like how much improvement we'd made. And so then we were all just like, oh, okay. So we are super excited. We've been working hard. We love our patients. So, and it's kind of a tight-knit community. So we want what's best for them. But I don't think I didn't realize it. I don't think any of us realized it until, yesterday. So I don't think it's set in yet.
and one of the things I'll say is, too often we think we either going to work well as a group, or we have to do what we need to do for our patients. And this is a really good example where you're doing what's best for your patients, and it sounds like it's even bringing your group together, and so it's kind of that win-win. And I think you're doing a great job up there. And as I said, a couple of the MAs were listening in, and it's like, well, we have to, what are we doing here in Swainsboro, Dr. Sheldon? So that chapter is yet to be written. So thank you.
Thank you for the comments and the question, Dr. Sheldon. Yeah, the gauntlet's down, and we're going to watch Swainsboro's numbers pick up. So Dr. Islam, you have your hand up.
Well, thank you. First of all, I wanted to thank you both presenter, Ms. McFarlin and Dr. Desai, for your wonderful and practical tips for increasing colorectal cancer. I really appreciate that. But my question is not rather clinical or theoretical questions, rather more practical. Dr. House mentioned that he has some family history, and that made him more enthusiastic or motivated to focus on colorectal cancer, and that's kind of his passion on that. I know you, Ms. McFarlin, you mentioned you love your patient, but is there anything that make you more enthusiastic to get doing the extra work that you were doing in addition to taking care of patient routine care that made you successful? Same question would be to Dr. Desai.
Thank you. So, of course, everybody knows somebody who's had some family member history of cancer, any kind of cancer. So there's that. We actually have a few patients, different cancers, different things we found out about patients, and it just kind of drives you a little bit harder to want to do the different screenings for pushing those screenings. A lot of it too is Soperton. So it's about 3,000 people. So if that's kind of small, well, not kind of, it is small. So a lot of times it's, oh my God, my friend, she's got this or he's got this, and then I need this. And so it's kind of like a word of mouth type thing, where we get, one patient, and then they, we may find something, or something may be found, and then we've got their whole family, we've got a whole friend group wanting to come in and get screening and get things done. We've seen that a lot as well too. And so being, kind of the only providers here, they like that they can come, 5 minutes up the road and get the services that they need. And so that's really important too. But yeah, it's personal. We love our 1,000 patients that we see. We wrap our arms around them and embrace them. And so that makes it easier. And then, like I said, if they hear about something, well, then everybody's coming. Everybody wants all the screening done. And so we've had that a few times as well.
Got another question out there, but a quick response from Dr. Desai to Dr. Islam. You're muted.
Yeah, thanks for that question, Dr. Islam. I think all of us that are on this call that are providers have stories of people that they know, whether it's personally or patients. I mean, I do mostly hospital work right now, so I get to see the really bad cases, so the patients that don't have screening. And you know, last month I was in the hospital. There was a 35-year-old. Now, of course, 35-year-olds aren't eligible for screening, but that just goes to show that she had, you know, stage 4 metastatic cancer, and we had to put her on hospice. And this was something that was, you know, really just goes to show you that this disease is affecting younger people. And at least for patients that are eligible for screening, we should at least work to prevent cancer in those folks. And so when I see things like that, that makes me, you know, even more motivated to do this work. So I think that's what it is, just the preventable illness that we see out in our community.
Thanks, Dr. Desai. Hillary McQueen, you have your hand up. Did you have a question or a comment? I seem to have lost you. Oh, goodness. Well, hopefully if she's still got a minute, maybe she'll get logged back on. She was right there. Okay. Yeah, I just noticed a comment from Cheryl Gabriel in the comments about raising awareness of symptoms and the disease prevalence in younger people. And so when we start talking about the importance of screening and dropping that age range down from 50 to 45 or that threshold, we're really talking about people who are still in their highly productive years and raising families and things like that. So the success stories that you will see in terms of keeping people, you know, as I hate to use the phrase contributing members of society, but you know, where they can take care of themselves and take care of their families. This is an incredibly important thing. I think Dr. Hotz mentioned a 46-year-old woman who had, I mean, she was barely over the threshold for screening, but she's got advanced cancer now for not being able to be picked up. So this is important. So if we're thinking about wrapping it up today, and we want to know if we want to have a key question, maybe that key question for the day is, what really is the value of screening champions? And I think we've heard from stories about personal stories, individual success stories. We've heard about the value of teams of champions as opposed to identifying a single champion, and helping everybody to understand that everyone who's involved in the team has a role to play. So I hope that you've heard something today that you can actually implement in your practice. And again, I think if I look at what all the work that I've done, not only with cancer screening, but with quality and safety and improving the patient experience, the force multiplier is these consistent daily huddles and being able to get people together to understand what the challenges of the day are, what are the opportunities, and the things that we're going to focus on. That's where you can review. You don't have to review your colorectal cancer numbers every day, but you can identify the patients and make sure that you're going through that as part of a cycle to keep it on top of people's minds. So that would be sort of what I've taken away from the session today. Please feel free to put comments in the chat. For those of you who are joining us from out of state, if you would like for us to contact you to see if you have opportunities to share your own experiences, Diana from Alaska, I appreciate you jumping in. We would welcome the opportunity to talk with you in more detail to see if there's an opportunity for you to contribute something in the way of a lecture or case presentation. So this is really good. There was a flash for CME. I'm going to turn it back over to Dr. Islam, though, and he'll close us out.
Thank you, Dr. Patton, for leading us through these presentations and discussions. I really appreciate, and thank you, Dr. Desai and Ms. McFarlin, for your wonderful presentations. Finally, I cannot thank more to the participants. I know you have a lot more important things to do in your life, but you chose to join us here today. And to show our appreciation, we bring a free, no cost CME and CNE credits for you for participation in this session. To claim your CME and CNE credit, please follow the link posted in the chat session or scan the QR code. Moving forward, we will need volunteer to present case study for our future sessions. If anyone has a particular case would like to present with ECHO session here, please email to au_crc_screening@augusta.edu. Before I close, our last reminder that our next session would be Wednesday, January 4th, 2023, next year. We hope to see you then, and we'll provide information through flyers in next 2 weeks. Thank you everyone for your attendance. We appreciate your and be safe and continue working towards increasing colorectal cancer screening. Thank you everyone. Have a good day.
Happy holidays, everyone.
Same to everyone.
Bye-bye.